going to talk about addiction assessment today. Somebody, you're going to move the slides for me. They can you can go on to the next one.
Okay, sure. Which button?
The right arrow.
Right. Okay, is that appropriate, Joe? Yeah.
That's good. You can keep going.
Okay.
So addiction assessment is important for pain treatment, folks especially who are getting opioids for pain treatment, and I'll talk a little bit about the why of that. I'm also going to talk about DSM-5 definitions of addiction and how they're relevant or not so relevant to pain treatment, and maybe talk a little bit extra about some of the patients who started on opiates for pain but have developed some problems and sort of where that line is around addiction, which can be difficult to discern. And then I'm going to talk about monitoring and aberrant behaviors during pain treatment and how to respond to those aberrant behaviors, taking in mind some issues around addiction. Next slide.
Oh, I'm sorry. It's me. Excuse me, Joe. Sorry.
No problem. I'll just wait until they go because I can't tell what I'm going to talk about without them.
No, you better tell me. I'll keep my head in the picture here.
So addiction is important in the treatment of pain, primarily around safety issues. Most deaths that happen with opioid overdose do involve multiple substances, and even if they're in the context of pain treatment, usually there's other things going on besides just the pain prescription. I think an average of 4 or 5 drugs is in the system of most of people who overdose. Pain treatment also with opioids is not going to be effective in the setting of an active addiction, and so keep monitoring for that is also important for the treatment of pain. And then looking at past addiction as a major risk factor for problems during opioid prescribing is really important. There are a lot of sort of risk factors for problems during opioid prescribing, but the one that comes through in pretty much every study is a history of addiction. And then addiction to opioids or other substances often does require some kind of specialized treatment. Now, that doesn't necessarily mean treatment away from the primary care setting, but sometimes it does. And so identifying addiction in that context is important. And then if you are prescribing opioids to folks who are actively using drugs, that's kind of the setting in which other authorities, DEA and the state can get involved, and sometimes prescribers get in trouble even if they're inadvertently prescribing to active drug users. So keeping track of this is important for a number of reasons. Next slide. And this is the slide of, what's the difference between being addicted to painkillers or just really liking them a lot, and that leads just into the diagnostic issues. Next slide. So DSM has changed how they are categorizing addictive disorders. They actually, in the chapter in the DSM now, actually use the word addictive disorders, substance-related and addictive disorders, and it's different from DSM-4, which called about which did not use the word addiction and used substance abuse and dependence as the terms. So addiction is a cluster of cognitive, behavioral, and physiological symptoms indicating that the individual continues to use the substance despite significant substance-related problems. And then the other aspect that they draw out in DSM-5 is that it involves brain changes that persist even beyond detoxification, and that these changes in the brain lead to craving and relapse. DSM-4 had some problems in their definition of addiction, and it led to confusion between what they called substance dependence, now substance use disorder or addiction, and the difference between that and physical dependence on a medication. And then there was really no clear evidence that the categories in DSM-4 of abuse and dependence are really separate disorders, and it's more of a spectrum. and prescribed medications were not dealt with. So people could have some symptoms that were related to physical dependence, even if they were taking the medicines fine and didn't have a problem with them. And those people would still meet criteria for under DSM for a abuse or dependence. And then there was also limited in DSM-4 limited specification of the severity of the problem, which is something they tried to change in DSM-5 in a lot of different disorders, not just addictive disorders. Next slide. So the major changes that happened with DSM-5 is that substance abuse and dependence is no longer what we call it. We call it substance use disorder, and there's one diagnosis, although it can be substance use disorder or a specific substance like alcohol use disorder or opioid use disorder. They added a criteria for craving, which was not a part of DSM-4. They also added a severity estimation and have categories for that. And they talk about prescribed medications and the tolerance and withdrawal that are reliably induced by some prescribed medications, including opioids, and they are trying to have criteria so that those don't count towards a diagnosis of addiction. Next slide. So here are the criteria. There are 11 of them. These are really just the same criteria that were abuse and dependence, just combined into one list. And the only other changes were they took out one, which is recurrent substance-related legal problems is no longer a criteria, and they added craving. Such a strong urge that you could not think of anything else is the way they describe it in DSM-5, and that's a way you could ask about that. The other criteria, really, there's tolerance and withdrawal, and we'll get to the exclusion for prescribed medication. And then the other issues are the same as abuse and dependence, trying to stop spending a lot of time taking or obtaining or recovering from use, taking more than intended, giving up important activities, using in spite of problems that are physical or psychological, having the substance interfere with major role obligations, use in physically hazardous situations, and then continued use in spite of social or interpersonal problems. So that's just the same criteria, and we'll come back to this a little bit. Next slide. So just to go through what DSM-5 says about substance use disorder severity, you can see if you have just one criteria, you do not meet criteria for substance use disorder. If you have 2 or 3, you have a mild disorder. And then moderate or severe are more criteria, and moderate or severe is what people think is most comparable to what we used to call substance dependence. So if you hit 4 criteria or more, you get that. And then the new tolerance or withdrawal exclusion applies to appropriate medical treatment with prescribed medications, and the individual has to have only symptoms that are those that occur as a result of the medical treatment. So tolerance and withdrawal only. So if they have other criteria, then the tolerance and withdrawal exclusion does not apply, and you would start to count the tolerance and withdrawal as part of the syndrome. So, Jim, could you go back one slide? Just go the other way with the arrow. So the issues with patients who are being treated with opioids who may be having trouble with their medication, it comes up a lot, and we're often asked in the addiction world to say, is this addiction or not? And the patient sometimes is very, it's kind of clear, and the patient agrees that they have a problem with the medications. Sometimes, though, the patient is taking the medication pretty much as prescribed. Maybe they're on higher doses, and there's been efforts to cut down, but they have had trouble with that. Maybe they're experiencing withdrawal, or potentially even increased pain with a taper. They want to come down. Maybe they've actually seen problems that they have or side effects that they have that they don't like, but they don't have the kind of typical addiction issues, going out and seeking drugs or spending a lot of time running around after them, or really serious role obligation difficulties, or physical or psychological problems, even maybe pretty minor. And yet we're asked, is this somebody who could get treated maybe with Suboxone? It could be safer, but we would be calling it addiction. And I generally, in those cases, a lot of it is context driven, and even if it seems like there are safety issues, they usually can fit into this category of substance use disorder. And if there are side effects, you can sometimes use those as criteria for addiction, and then even the desire to cut down because they see some problems but not being able to do that. I kind of think of that as addiction issues, and substance use disorder can be diagnosed. Some patients may not like that or may have problems with that categorization, but they may fulfill the requirement and need some discussion about, well, this is a separate disorder that we can treat, and that it doesn't necessarily mean you're a bad person, even though in our society addiction is often associated with bad people doing bad things. So you could go on to the next slide and then the one after that. So the opioid risk tool is something you hear about a lot in our UW. TelePain as a general kind of tool that we use to just highlight the risk of prescribed opioids. And you can see the criteria, their family history, personal history, like I mentioned, of substance abuse, younger age, pre-adolescent sexual abuse, psychological issues, and those are the criteria. And this is not really hard science. This is pretty soft science, but the opioid risk tool does predict problems with opioid prescribing pretty well. There are other tools that do it, some a little bit better maybe, but have more questions. So this is kind of a balance of, it's pretty quick to do, and it kind of at least gets your attention if a lot of these things are positive. There isn't any, there's low, moderate, and high there. And I think you just need to realize that the personal history of substance use is really the main one. Although there certainly these other issues may contribute as well to the use of this index. So next tool. So getting an addiction history in a patient who has chronic pain, especially when on opioids, can be challenging. Patients may have really good reasons not to disclose addiction problems if they fear that their opioid medications won't be prescribed. So there is some problems with it. There's no way really to get around that other than to really try and establish rapport in other ways. And that, I would say, is the number one job. If you demonstrate that you're listening to the patient about their pain, which means really listening to their story and trying to reflect some of what they say so that it's clear to the patient that you've heard what they have to say. That's, in my experience, the best way to establish rapport that might lead to a little more disclosure if there is a history of or current drug use or alcohol use. There, in primary care practices, there's actually pretty good evidence that screening for at least alcohol problems using validated questions is an effective thing for all patients. The validated questions are how for alcohol really are how often do you have more than 4 drinks if you're a woman, or 5 drinks for a man. 4 or more drinks or 5 or more drinks in an occasion. And if in the past year, if that has even gets an answer of any use, then at least it's worth more conversation in a screening setting. In a patient who's on opioids, I think that the screening thing is not necessarily the best approach. And I tend to want it to be more about a conversation, and tell me about your drug and alcohol use is a pretty reasonable open-ended question that you can use for patients who are coming in with pain issues. They it gives the patient the option of choosing which things to say, what's important to them. You might get some stuff about I'm not an alcoholic or I'm not an addict, but trying to understand what they mean by that, and it can be helpful. And if they do have concerns about use that they've had in the past or currently, you can try and reflect those and encourage more disclosure. Really, I think the conversation that is non-judgmental and empathetic is going to get more disclosure. You can use the checklist, but I don't usually do that. Next slide. And then if patients do seem to minimize current use of alcohol or drugs and you're wondering about that, I think asking about these issues in the past is a lot less threatening. You get a lot more disclosure of past problems, even when people were a teen. But since addiction is really an adolescent onset disorder for the most part, not 100%, but most people who have addiction have problems in adolescence. It's really quite a good way of getting the sense of whether somebody does have a history of addiction and do therefore have higher risk for opioid prescribing. Assessing the past problems, how bad did they get, what kind of treatment was done, and really supporting patients' past efforts to quit. And they may really see that even if that their current use is nothing like it was when they were an adolescent, and therefore it's not a problem. And I think you can demonstrate your understanding of that by reflecting just that kind of statement from the patient. I do look for sort of the recovery story. If people were in treatment at any time, had severe problems, usually it's kind of hard to stop. And if the problems were severe, people usually do have some kind of story about how they were able to overcome the problem. If they have such a story, or if they have past problems that are severe, but they're using even at low levels, I do consider that a really higher risk, because they're kind of always at risk for going back to a more severe problem. Next slide. So the monitoring of patients on opioids is really important, and we talk a lot about your toxicology testing using the prescription monitoring program to check. And I think getting this monitoring to be clinic policy and something that's as automatic as possible and not sort of based on a provider's level of suspicion of a patient is really important. So everybody's getting it, and it's kind of just what we do to make everything safer. People understand that. People who have low risk and haven't had problems understand why we're doing it. So I don't think it should be a issue of conflict between patients and providers. You can increase the intensity of that monitoring if there is higher risk, and if you do have concerns, getting more information is always a good idea. And framing that as assuring safe prescribing, especially if there's a past addiction issue, trying to make sure people don't have problems and you're supporting their recovery. And really, these kind of problems that emerge with opioid prescribing generally emerge over time. Sometimes you can see them coming right away, and sometimes you're surprised. But I think that's why we're doing the monitoring. Next slide. So the kinds of aberrant behaviors that you see in primary care practice or medical practice, having a lot of early refills or running out of the medication, therefore taking it not as prescribed, unexpected urine results. I think behavioral problems noted by staff is one that I see a lot of mistakes made by providers who don't pay attention to their staff, or the patient's really nice to them but not to their staff, and that's really got to be a red flag for people. The staff interacts with a lot of patients, and if they're identifying problems, it's really, you need to pay attention. And then unexpected prescription monitoring program results is another kind of aberrant behavior. And then the last one, which most people may not sort of see as true aberrant behaviors, if you've made a plan for treatment of the pain and the patient isn't following through, missing appointments, those kinds of things. I consider that a version of aberrant behavior. It may not. It may lead to different response than the urine tox for positive for cocaine. But I think of it as an aberrant behavior and something that needs to be addressed. Next slide. So it's really important to respond to any of these kinds of aberrant behaviors. I think because safety is such it can be difficult to figure out if there's a safety problem. If you're only seeing the patient, even if you're seeing them every month, it's pretty tough to tell. So there's the issue of the tip of the iceberg. And so I think recognizing that we're not perfect in one encounter, figuring out what's going on with a patient is you just have to have that humility and take responsibility for getting more information if you need it. The aberrant behaviors may not reflect an addiction at all. It may be a mental health problem. Depression is really common when people have aberrant behaviors. Diversion is another issue, and of course that's one that can be difficult to discern, but it is a possible cause of aberrant behavior. And then new social stress, I just see it a lot of the time when people have problems with their medical care and sticking with it. New social stresses, they moved, they broke up with somebody, they lost their job. And these are things that are important to identify. If you ignore the signs of aberrant behavior, I think it does make it more likely you'll have problems with the authorities, but it's really more of a patient care issue, I think, most of the time, and trying to find that diagnosis that maybe you didn't have before, so that you can provide better care. And then if you overreact to these to aberrant behaviors, I think there may be people who are getting appropriate pain treatment who lose it for not great reasons. So it is something to just consider. It's important to respond, but it requires some care. Next slide. So just in terms of strategies when there are aberrant behaviors, I think prompt response is good. If you have a urine test result that's positive, not expected, often what I'll do is just ask the patient to come back before the next meeting when I know they're supposed to have some medication. So between dispensing visits, have them get their medicine counted and have a random urine test. If that makes things clear, it just saves a lot of time. And then discussing the aberrant behavior with your patient and trying to figure out what kind of response you're getting. There could be a new stress or the what's been going on lately kind of question for me can often identify the new stress or the worsening diagnosis. And if the patient is really vague or defensive or it just doesn't make that much sense, then you have more information and realize you have to get more information along the way. And people may not understand about how they're supposed to take their medicine, and it's an opportunity here to clarify that. Next slide. And then once the increasing treatment intensity, especially if it's not clear what's going on, can be really important. If there is a new issue, you of course have your referrals or tests or follow-up for that new issue. A lot of times patients have behavioral coping strategies for their pain, and that work for a time, but they kind of fall out of use just because behavior change is difficult, and it may be an opportunity to reinvigorate those changes. If you've identified a patient who used to do a bunch of really healthy things and then they had to move and they just didn't keep up with it. And then the patient's response to that increased treatment intensity, again, is really important and can help clarify if addiction is there or if there are other problems coming up. And then if you're having trouble with this, which I think I often do, then getting help from an opioid review committee or a team meeting or TelePain is really helpful when you're trying to deal with these behaviors. Next slide. So clearly, the way I've described aberrant behaviors, some of them are a lot more dangerous than others. If you overdose and are seen in the ER, it's really different than missing your physical therapy. But and so the urgency of response really depends on safety issues, and recognizing that lower doses are safer. It can be an opportunity to lower a dose that you're uncomfortable with. There is the possibility that you need to get a different setting for opioid use, i.e. addiction treatment, or a different level of care if they if they really do show signs of addiction. And then the transition from pain management to addiction treatment, it can be complicated. It does require the patient to be on board with they're having an addiction problem, and if they're not on board for that, then I think you are sort of left with it's not safe for me to prescribe, and and that may be all you can do. But if you can help people understand that addiction is a primary medical diagnosis, and that even people who have moral character can have addiction, then I think that's a better way to go. Next slide. If you're stopping prescribed opioids, obviously some behaviors don't require that, and some settings don't require any kind of taper. If it's a diversion issue, you call them back after they're positive cocaine urine and they don't have their medicine, then you're kind of done. And low dose opioids also, they're not going to have withdrawal from those doses, then that's not really an issue. But folks who are on higher doses, I think the consideration for opioid addiction treatment with a medication, buprenorphine or methadone, is really something we should try very hard to provide. If patients do have addiction problems, they really do need a medication, needs to be delivered in a safe way, and methadone obviously is delivered more like directly observed therapy, so that's why it's safe. Buprenorphine, by the nature of its pharmacology, is a lot safer than other high doses of opioids, so both of those improve safety as well as address the problem of addiction. And team approach to making these kind of decisions is really helpful. Next slide. I see a lot of patients who come and say, my doctor fired me or my clinic fired me, and I think I always flinch when I hear it. I don't know if it's true, but I really think it's important to disconnect the prescribing of opioids from the stopping of care for pain or other medical problems. If there is an addiction, you might need help treating it, or you might be able to do it yourself with buprenorphine, but that doesn't mean that you're not going to be taking care of the patient's medical issues, and even their pain can be addressed if they're getting addiction treatment, and it's actually a lot easier to provide that pain treatment if they are in addiction treatment and their opioid receptors are stabilized. So really try and avoid this. I mean, patients will sometimes feel like if you're stopping prescribing, you're not helping them anymore, and therefore you're firing them. But that should be something that they're over-interpreting. That shouldn't be something that you are pretty explicit about. And if you're going to stop opioids, that you are willing and want to try and continue to help them. Next slide. So this is just a summary. Addiction is really important in the management of pain, especially when opioids are used. Diagnostic tools do have their limitations, and there may be different kinds of diagnostic presentations that come up in this setting. The monitoring and responding to aberrant behaviors are really important to discovering addiction problems in this setting, and you really want to assure that treatment happens if you make that diagnosis, knowing that in the case of opioid addiction, methadone and buprenorphine are really the mainstays of treatment and the only way you're going to have success in treatment. So that's the end of the talk.